Yes, sir. We are live now.
Yes. Good evening, everyone. Today we are here with the another episode of ACP India Case Files, and today is a very special episode because we have a very interesting case, and we have very esteemed faculty with us. But before we do that, I would like to welcome our Governor, Dr. Anuj Maheshwari, who is behind this program. And this program, he will tell us more about the program and everything. So I will like to invite Dr. Anuj Maheshwari, sir, who is professor in medicine at BBD University at Lucknow. He is also the governor of ACP India Chapter, as you all know, and he is also the vice president of RSSDI and also the International Society of Hypertension. So welcome, sir, with a small welcome note from my side. And now you can please proceed with your address.
Thank you, Amit, for the kind introduction. Greetings to all members of the American College of Physicians, India and abroad. This award-winning program, which has been awarded the John Tucker Evergreen Award for this program, is again before you with a new edition of this. And this edition has a very interesting case of diabetes in a young person. Now we know that across the world, diabetes is increasing in the young individuals, in the adolescents also, in the teenagers also. And bad thing is that type 2 diabetes has also started increasing in this group of the people. Before, we were knowing that only type 1 diabetes were known in the adolescents and children and teenagers. But now we see insulin resistance is also increasing in this group of the people. Apart from that, a lot of lifestyle changes are also responsible for that. For that discussion on young individuals' diabetes, we are here with Dr. Prabhat Agarwal, who is the professor in Ascent Medical College, Agra. And the session will be moderated by Dr. Sanjay Kalra, who is a well-known endocrinologist of the country. And Dr. Sanjay Kalra is a person who has headed already number of societies, including the International Society of the Endocrinology as well as Indian Society of the Endocrinology. And he is a big name in the endocrinology. Second session, which is usually dedicated to our day-to-day activities, life planning, year planning of the early career physicians. In that segment, this time we are coming up with a very innovative thing which has not been discussed before. How can our members be upgraded to fellowship? How can the advancement of fellowship be done? And what are the advantages of being advanced to fellowship of American College of Physicians? For that discussion, our earlier governor, is the immediate past governor, Dr. Muruganathan sir, is with us, and he will be telling you about how can we really move on to the upgradation. Dr. Muruganathan is a person who has given the ACP India chapters a very good and new heights, and we have got good success of this chapter seen in his tenure. He is having a lot of academic accolades as well as awards. He is the BC Roy Award winner from the President of India and received the Lifetime Achievement Award by Tamil Nadu Dr. MGR Medical University and Suvita Medical University, KG Foundation, Dr. Mohan's Diabetes Foundation, of course, an Indian Society of Hypertension too. And he has been received the Best Performing Doctor Award from Tamil Nadu government on Doctor Day 2014. So without wasting much time, I will request Dr. Dr. Sanjay Kalra to take over the first session in which he will be moderating and he will be inviting and introducing the speaker who will be presenting a case of a young diabetes patient. Over to Dr. Sanjay Kalra.
Thank you, Dr. Anuj, and warm welcome to everybody who is logged in today from India and from across the world. Now, diabetes is a very complex condition, and it's like a chameleon. It keeps on changing its face. The beauty is diabetes changes from person to person. It can sometimes change within the same person. So as a physician, if you are able to diagnose diabetes, but you are not able to diagnose the type of diabetes in the first clinical encounter, that is not an issue at all. You just don't need to worry about that at all. You can tell your patient also upfront that, this is what I feel you have right now. You have diabetes, the type of diabetes that you have, I understand your concern. I understand you want to know about that, but let's see how the syndrome evolves. It can worsen, it can improve, it can remain static. So let's just see how things go. This diagnostic dilemma is important, and that's why we have with us Professor Prabhat Agarwal. I'd like to warmly welcome Dr. Agarwal. He's a professor of medicine at the prestigious SN Medical College in Agra, one of the oldest medical colleges in our country, actually. And he's well known in academic circles for his contribution to diabetes and medicine. So, Professor Prabhat, warm welcome to you. And what is the case that you are sharing with us? And what is the diagnostic dilemma? How did you overcome it?
Sir, should I start?
Oh, yes. Warm welcome, sir. Carry on.
Thank you, Dr. Sanjay Kalla, sir, and our governor, our past governor, dear Amit Bhai, for giving me this opportunity. My slides are visible?
Yes, your slides is visible and your voice is audible.
Okay.
Please.
So, good evening to all, gentlemen, participants. Today I'm presenting a case of 23-year-old male who came to me, our emergency casualty department, with a GTCS. He was a known case of GTCS, and he presented to us in the disoriented state. According to the previous physicians and the documents of previous hospital, he was the diagnosis case. We diagnosed a case of a diabetic ketoacidosis. Nothing new. Everything is almost normal. When we shifted him ICU, just according to the COVID protocol, according to DK protocol, managed conservatively with the insulins and the IV fluids, he improved after 2 days. But when he improved his from the consciousness, he complained of the poor vision as well as the hearing. Slide move कर रही हूँ. Just one second.
So once click on the center screen, then try to move on.
Yes. But while we wait for the slides to move, this is important. And now this tells us about the need for good clinical acumen. Patient came in with disorientation. It could have been a neurological disease. It could have been a metabolic disease. And let's see how Dr. Prabhat tackles this case. Carry on, sir.
Yes, sir. Now it's moving.
And this is how sometimes diabetes behaves. You know, sometimes you get hyperglycemia, other times hypoglycemia. And this is what happens with our slides also sometimes on Zoom. Sometimes you move too fast, sometimes too slow. And I learned this wonderful English word. So I feel very happy and proud when I learn something new in English. So the word is funambulism. Funambulism. Ambulatory, we all understand. Funambulism is supposed to mean that you are having fun while walking. But actually, funambulism means walking the tightrope. And that is what we are trying to do today. Walking the tightrope of staying in between the fast slides and the slides not moving at all. Dr. Prabhat, we are comfortable with the slides now, if you are comfortable as well.
I think that Dr. Prabhat is changing his system, or I think he's trying to fix some problem.
So, but let's take the discussion forward, and in the comment section, if you can put in any comments, what comes to your mind? Somebody coming in with altered sensorium in the emergency. What is it? Will you think neurology? Will you think cardiology? Will you think metabolism? Will you think endocrinology? What comes to your mind immediately? Will you think toxicology?
Most of the time, sir, it comes that something is neurology. Many people think that something happens with the neurology. Toxicology may be one of the very important reason in our routine clinic practice, but rarely we think about that. that remains a diagnosis of exclusion many times unless it is not very visible sign or some bluishness we are seeing. Then otherwise we think like that something happened with the stroke kind of the things like.
Dr. Riaz points out that in his practice, metabolic is what he thinks, first of all. So how do we decide metabolic or toxic or endocrine on one hand versus structural on the other hand? How do you look for localizing signs? What is the immediate thing that you would do maybe within 5 seconds? Let's see if there are answers coming in the chat box. How would you search for localizing signs? And then in parallel with that, we ask another question. Supposing there is a localizing sign, someone has a focal seizure, someone has a localized neurological dysfunction. Does that rule out hypoglycemia? Does that rule out diabetic ketoacidosis? What can happen if you have a snake bite? You know, there are so many things to think of. So let's see what comes up in the chat box.
I think, sir, differential diagnosis of a young male presenting to the emergency department with altered sensorium, I think it involves all the categories which you have pointed out. And just by simply, then obviously we will take the detailed history which is available and the circumstances in which the symptoms were there. So that will help us in further understanding that what was the probable reason. For example, if it is a toxicology, then probably there would be some history of some consumption of some poison or some other things. Snake bite, you will have some bite marks. And if somebody is having some, for example, infective disorders can also present like this. Sometimes meningitis can also present like this. So the background of any fever or any what was happening there, or is it a sudden onset? So any history of even a hypertensive hemorrhage can present like this. So I think the entire internal medicine comes into picture when you have a young male coming to you with an altered sensorium.
And the examination will come later, but the history tells you. It also depends, on which part of the world you are living in. Where I live, the first diagnosis would be alcohol intake, actually. That is the first thing we would look for and we would smell for. I am also reminded of a very funny incident, and I would like everyone in the group to comment, the juniors, the seniors. Dr. Rajneesh Kumar says hypoglycemia, and that is right, Dr. Rajneesh. Hypoglycemia is a major cause. It can cause an ictal seizure. It can cause a seizure. It can also mimic a seizure. So both things are there. Similarly, hypoglycemia can cause ischemia, cardiac ischemia, and it can also mimic ischemia. Alcohol is one cause, and alcohol withdrawal is another equally important cause. That's right. The incident I'm reminded of is that I asked one of our juniors about, I think maybe 5 years ago, what is the difference between acute meningitis and diabetic ketoacidosis? So the answer was, sir, in acute meningitis, there will be loss of sensorium. In diabetic ketoacidosis, there is no loss of sensorium. The patient is not comatose. So that made me smile, it made me laugh, and it told me about how diabetes management varies according to the ecosystem that you are living in. If you're living in a primitive healthcare ecosystem, then you will see each and every presentation in the book due to DKA or hypoglycemia. But if you're living in a developed part of the world, where patients do take care of themselves, where they do take care of their health, their diabetes, then you will encounter diabetic ketosis, but you will not encounter diabetic ketoacidosis. Even if you encounter diabetic ketoacidosis, then you will not encounter diabetic ketoacidosis coming in coma grade 4. So it actually depends upon the area of the world that you are living in. And this opens up a discussion. How do you see DKA in your practice? And how do you see meningitis? And it is important to get this feedback because each of you will be right based upon the ecosystem that you are living in. The presentation of a disease like encephalitis or meningitis will vary immensely based upon your geographical area. And the presentation of diabetic ketosis or ketoacidosis or HHNKC or even hypoglycemic coma will vary upon the quality of the healthcare ecosystem that you find yourself in. So we are happy to take comments, and thanks, Dr. Rajneesh. Differential, okay. The differential for this young man is hypoglycemia. The patient fell due to hypoglycemia and might have got a hemorrhage or something, and also acute bacterial meningitis, right? So lots of differentials coming up. Thanks, Dr. Rajneesh. Friendly question, Rajneesh, where do you practice?
Good
Dr.
evening,
Amit?
sir. Myself, assistant professor in general medicine from Government Medical College at Nainital, Haldwani in Uttarakhand. And recently, I've completed my SRship from Safdarjung Hospital. I'm a graduate and postgraduate in medicine from Safdarjung Hospital only, that Bardhaman Mahavi Medical College.
Right. Thank you, Dr. Rajneesh, for joining us. And how does it feel to be in Haldwani, where maybe the investigations may be limited? Does that make you a better physician or a worse physician if you have to
Sir,
rely more on clinical acumen?
only 2 days I've been able to join here only, so I do not know much about that. Recently, I've completed my SRship from Safdarjung, so I cannot tell exactly at this point of time regarding these things what you are asking, sir.
But
So I need some time more to evaluate
right.
about the possibilities here that I could get for the patient.
But Mubarakbad to accept karo. Please accept our congratulations. Dr. Anuj, would you like to add anything to this? I feel very happy when I see our young boys going and girls going back home.
Yeah. Yes, definitely. It's very good that young people has joined, and I think it is very good that we have combined it with the advancement of the fellowship. Then these people will be benefited apart from getting benefit of this case, as well as they will be knowing that how can they be advanced to the fellowship. You are very correct in your observations, and I also feel sometimes if a person is non-diabetic and he develops any such kind of the inflammatory process inside of his body, like infection, like something else, and some viral or bacterial, then first thing we always think, and we should think, that is hypoglycemia. Probably his glucose regulation must have been irregular and must have been disturbed, and because of what he might have been falling in because of the hypoglycemia. But apart from this, we also see sometimes the hyperglycemic coma also in many patients. We also see if a person is of the type 1, because the age group is 23% maybe of the type 1, then DK may be one of the possibility. So these multiple things may be on the endocrine perspective, but at the other side, obviously, this is not a very good age of getting the neurological disorder, neurological problem, stroke kind of the thing. But obviously, we can always think about the infective pathologies like viral meningitis. In Uttar Pradesh, we see the Japanese encephalitis kind of the thing. And these things may lead to altered sensorium and unconsciousness in such kind of the patient.
Dr. Manisha has helped us out, Dr. Manisha Gupta. So she says that in meningitis, you will see a prominent triad of fever, headache, and vomiting, along with the altered sensorium. These can occur in diabetic ketoacidosis as well. In DK, actually, on the other hand, fever may be suppressed. The patient may have an infection, but you will find that the TLC will not be reflective of the infection. Because of dehydration, the TLC may be increased, and also it may be reduced. So this is the difference between meningitis and DKA. And another difference is, like she points out, that is neck stiffness. You will find neck stiffness in meningitis, but not in DKA. Dr. Prabhat is back with us, and we request him to continue the case.
Sir, may I proceed?
Yes, sir, certainly.
So when we examined this gentleman, everything was normal. There was no neurological deficit, no meningeal signs of irritation. There was no plantar extensor. Everything was normal. So we managed him conservatively on the lines of the DK, and he became all right almost after 2 or 3 days. He insisted me for the discharge as he was one of the poor patient. So we discharged him on basal bolus regime of the insulin. The impairment of the vision hearing start improving after 1 week when he come up in our follow-up, and it was completely improved after 20 days. For further taking history, he was taking antiepileptics since childhood, as he's a known case of GTCS for last almost 15-16 years. And currently he's on levetiracetam and the sodium valproate. When we took the family history of this patient, her mother was also diabetic, and she was diagnosed diabetic at the age of 23 years. She was well managed on OHA, and she was saying कि सब गांव के किसी पेशेंट डॉक्टर से मिल रही थी और मेरी शुगर कंट्रोल थी, but she also complained of the hearing impairment like in our patient, but she expired at the age of 29 years age. His younger sister was also diagnosed diabetic at the age of 18 years. She also had hearing impairment, but unfortunately she expired at the age of 20 years due to some acute complication of diabetes. They don't know, they don't have any records, most probably maybe because of the hypoglycemia or the decay. His father is non-diabetic. On further elaborating history, his maternal grandmother, that is Naniji, was also diabetic, and she diagnosed at the age of 40 years. His two mamajis, that is a maternal uncle, was also diagnosed diabetic at the age of respectively 20 and 22 years age. And both mamajis had impairment in hearing. So all patients who were suffering with the diabetes in this family had the impairment in hearing. His elder maternal uncle, Mamaji, expired at the age of 26 years. His maternal aunt, means Mosi, was not tested for the diabetes, but she expired at the age of 24 years due to postpartum complications. So in her maternal side, her Nani was diabetic, his both Mamaji was diabetic, her Mosi was not diagnosed, but she expired due to postpartum complications. So this was the pedigree analysis of this patient. Low one is our patient that is having the this patient is a patient that is having male, having diabetic, having impaired hearing and the vision loss. This is a sister of that male. She expired at the age of 20 years, but she also had diabetics and she also had a impaired hearing. Patient has extra vision loss, but her sister did not have this. Mother of this index case expired at the age of 20 years. She was also having diabetes as well as the impaired hearing. One of the sisters of this, his mother was not having diabetic, but she was not diagnosed till his death. His two maternal uncle both have diabetes, both have impaired hearing. One maternal uncle, elder maternal uncle, was expired at the 25 years, and one maternal uncle is still, and he is on OHS. His Naniji, which expired at the age of 40 years, she had a diabetes and she also had an impaired of hearing. Her Nana was not having diabetes. So this was the total pedigree analysis of this patient. So this was the, so thus now, what the things come to our mind, why it may be the type 1 diabetes, it may be the type 2 diabetes, it may be the Modi, or something it may be the fresh type 2 diabetes. There's so many differential diagnoses came to our mind. But when we look for the literature, it was a total maternal side diabetic was there. So thus on the basis of his strong family history, maternal inheritance, hearing and the vision impairment, we suspected MIDD, that is a maternal inherited diabetes and deafness. So we sent her blood sample for the genetic analysis, which suggested A2J substitution at position 3243 of the mitochondrial DNA. And this is the report of this patient. Here you can see this was the mutation. Heteroplasmy was the 56%. Heteroplasmy is responsible for the phenotypic presentation of the MIDD. If more is the heteroplasmy, more is earlier the symptoms. If lesser is the heteroplasmy, lesser will be the presentation, lesser will be the symptoms. So heteroplasmy was the 56%. For GTCS workup, as he was having GTCS for since childhood, MRI brain was done, which showed gyral swellings and hyperintensity. We also look for the CSF lactate levels, which was very high, means patient is having also lactic acidosis. That was a 56.4. Normal value is 10 to 22 milligram per deciliter. When we look for the ophthalmic examination, it suggested maculopathy. We also look for the pure tone audiometry, as he also having the hearing impairment, which showed the bilateral sensorineural hearing loss to the high tones. This was the pure tone audiometry of this patient, which was suggested of the bilateral sensorineural hearing loss due to high tones. This was the fundus examination of this man, showing maculopathy. This one. So all this was having the maculopathy. So we managed H in MIDD, sodium valproate can cause lactic acidosis or can precipitate seizure. So we avoid it, and we add clovazam, that is a frisium. We also added coenzyme Q10, as suggested by some studies that it can delay progression of hearing loss compared to placebo. We also started sulfonylurea, glavencalamide, 5 milligram twice a day, along with the insulins. So currently, patient is on sodium valproate along with the frisium for the management of the seizures. Till then, he is not having seizures. After adding coenzyme Q10, practically there is no improvement in the hearing or the vision, but still we are continuing and we are providing patient from our pocket. But patient blood sugar is markedly improved after adding glibenclamide, that is a sulfonylurea, and currently after apart from this glibenclamide, he is on Mixtard 30/70 insulin, 15 units morning, 18 units evening before meal. This is a summary of the MIDD. It is a very rare form of the monogenic diabetes that relates from a A2J mutation at 3243 of the mitochondrial DNA. And the clinical presentation of this MIDD is very variable because of the heteroplasmy, and sometimes ranges from mild to severe phenotypes. This type of diabetes is usually accompanied by sensorineural deafness, cardiomyopathy, neuromuscular, psychiatric disorders, macular dystrophy, and sometimes renal failure. The thing which was not usual or not seen in the MIDD, but it was present in DK, as DK is not commonly seen with the MIDD, but when we look for the literature, around 8% of the patient of MIDD present sometimes with the DK. As patients were not affordable for further GAD antibodies, so we did not advise this, but usually this type of patient MIDD doesn't have GAD antibodies positive. Hearing loss in MIDD is usually sensorineural type, and it's a cochlear origin rather than cranial nerve origin. Few patients of MIDD have a combination feature of MELAS. MELAS is a mitochondrial encephalopathy, lactic acidosis, and stroke. As our patient is having lactic acidosis, when we look for the CSF lactate level, so it is somewhere with the combination of the MELAS along with the MIDD. Some patients of this MIDD can have psychiatric disorders in the form of the depression, sometimes have schizophrenia, variety of the phobias. The most common ophthalmic feature is a macular retinal dystrophy. Some patients of MIDD can have myopathy. Our patients are not having myopathy, and it is usually proximal limb muscles, and it manifests as exercise-induced muscle cramps or the weakness. This type of patients have a very high prevalence of developing end-stage renal disease, but the renal biopsy may show features of diabetic nephropathy, but the most prevalent finding is the FSGS. That is usually not seen with the diabetic nephropathy patients. But sometimes these type of patients present as a proteinuria in early adulthood, particularly in the women. Premature deaths are also seen because of the cardiac cause. And in young adults, rapid progression to symptomatic heart failure over 4 to 2 months has been described. We did our patient's echo, and it was absolutely normal. There was no tachycardia, or there was no type of any extrasystole or the arrhythmias. Left ventricular hypertrophy, cardiac autonomic neuropathy, atrial fibrillation, frequent ventricular atrial systoles can be seen. And most common endocrine manifestation of MIDD is short stature. Our patient height was 5 feet 4 inches, so it was almost normal, as his family father was also having 5'4", 5 and 5. So take home message from my presentation, that abnormality of glucose metabolism in MIDD is associated with gradual decrease in insulin excretion due to reduced ATP production in pancreatic beta cells with abnormal mitochondria. This diabetes and hearing loss can develop in the mid-adulthood, usually in the 20 or 30 years, as seen in our patients. It develops at the age of 23 years. And most often disease is diagnosed between the 2nd and the 5th decade of life. This rare cause of diabetes should be suspected in the case of the maternal inheritance and concomitant deafness. Additional tests which can help us normal or the reduced level of C-peptide and the normal autoimmune markers like GAD65. Most often hearing loss occurs before diabetes, and the coexistence of deafness and the mitochondrial diabetes in patients with M3243 A2G mutation is found in only in 60% of cases. It is not seen in all 100% of cases. So if still mutation is not there, then we can't exclude the diagnosis of this MIDD. For the management of seizure, we should avoid sodium valproate as we avoid in this patient, and metformin should not be prescribed in such type of patients, as it can theoretically it can cause lactic acidosis. So initially these patients are managed with the sulfonylurea, and later on we can add insulins. So with this was my case.
Thank you, Professor Prabhat. Very well presented, a very interesting case and something that opens up our minds to the infinite possibilities that we see with diabetes. We began thinking about decay and see where we have finally reached. So that is the beauty of our subject of internal medicine. Any comments, any queries from people who are logged in from across India, from across the world? I see many, so many names, so many enthusiastic people having logged in. We'll talk about the management, but there is something that we always forget, and that is genetic counseling. Many times people come to us in the OPD, people with type 1 diabetes. They want to marry another person with type 1 diabetes, and they are worried, will my child get type 1? That is a separate matter. What about this particular patient, Dr. Prabhat? What genetic counseling would we offer to him? Does his child have a chance of developing MIDD? And now, suppose he has a sister. What answer would you give to him, and what would you give to his sister?
So as this as this is a maternal inheritance, so this gentleman cannot transfer this diabetes MIDD to their kids. But as her sister, which was expired unluckily, so females can transmit to their kids, but males cannot transmit.
So that is one positive about this. The child will not be affected.
Yes, sir.
You also spoke about not giving metformin because it is an insulin sensitizer. There is actually no issue with insulin sensitivity in
Yes,
this
sir.
particular patient.
Yes,
So
sir.
one treatment is insulin, another one is sulfonylureas.
Yes,
Now
sir.
we have new drugs like DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors.
Yes, sir.
This patient, like you described, is not obese. He is normal weight.
Yes, sir.
And he came in an emergency. How would you feel in your setup prescribing an SGLT2 inhibitor or GLP-1RA or DPP-4 inhibitor to this patient? Would you be comfortable or not?
I look for the studies. They mentioned that we can we can prescribe for the DP4 inhibitors, and I found in one literature that we can also prescribe SGLT inhibitors. But one or two studies refused for the SGLT inhibitors in this such type of patients. But they 2 or 3 studies mentioned that they can prescribe DP4 inhibitors. So SGLT inhibitor I can't say, but DP4 inhibitors can be prescribed.
Can be used. But the safest would be sulfonylureas and diet for a short period of time. And then when it stops working, sooner or later they will stop working. Then we have to move to insulin. We should counsel the patient about insulin right on in the very beginning. SGLT2 inhibitors, let us ask other people to share their comments. In general, what I would say is if your patient is unstable, patient has come to ICU, then that is the last thing you will think of. But if your patient is stable, like now the patient is continuing on follow-up with Professor Agarwal, Dr. Agarwal is confident that if there is any problem, the patient will come running to him and will come running, will not come lying down in the ICU in coma. Then we can think of using SGLT2 inhibitor from a cardiovascular point of view. And I doubt if there will be any randomized control trial that will study the CV outcomes with SGLT2 inhibitor or any other drug in a person with MIDD. That is highly unlikely. So that brings us to another point. And this is what we call, Professor Prabhat, good clinical sense. Good clinical sense is something that you develop as a physician, as a professor of medicine. So can you tell us what came to your mind, intuitive things, when you saw the patient in coma, when you saw the patient waking up? What happened to your neurons? What kind of Brownian motion occurred which made you think of MIDD? So, which is not written in the book. It is there just in the good clinical sense. And you would have learned from your professor.
So when patient came to me, his father said कि सबको डायबिटीज है हमारे यहाँ, इसके नानी पक्ष में सबको डायबिटीज है और सब जल्दी मर जाते हैं, इसकी बहन भी मर गई, इसकी माँ भी चली गई, इसकी मौसी मामा भी चला गया. So very unusual thing, मैंने कहा अगर type 1 होता तो type 1 is not runs in the family, especially maternal inheritance. Diabetic का भी सर ऐसा नहीं होता है. So I think that was something unusual. And the second important thing that was the deafness. वो उसमें एक ही बात कही कि सब जब भी डेफनेस मतलब डायबिटीज होती है तो डेफनेस के एपिसोड्स आते हैं. इट वाज व्हिच आई फॉरगेट टू मेंशन दैट इट वाज एपिसोडिक moments of the this vision loss as well as the this vision loss and the deafness. So whenever his sugar is impaired, gross suppose blood sugar goes up to the 400 300, he missed insulin because of the affordability. So he started developing these episodes of the deafness as well as the vision loss. Otherwise, he's okay. So this was unusual things which came to our mind कि there is something कुछ तो गड़बड़ है जो इतना commonly नहीं है. So when I look for the literature, then it came to my mind there is one entity. One thing also came to my mind, that was a Wolfram syndrome. That is also diabetes insipidus, diabetes mellitus, optic atrophy, strokes. So, but it was seen that it was the type 1 diabetics, and usually it's very, very rare, less common than even than the, this MIDD. So, but in the MIDD, in this Wolfram, there's optic atrophy, but in our patients, it was not optic atrophy, it was a macular edema. And the deafness was not explained by the Wolfram. So, and this was not any feature suggestive of the diabetes insipidus. So I restricted myself to the MIDD. And when I advised him for this genetic mutation, then it luckily it can turn out to be positive. As I look for the literature, it was seen that it is not necessary that is always come positive, and because it depends on the heteroplasmy. So in our case, it was heteroplasmy was very good, 56%, and it was from the this blood cells. Otherwise, sometimes we need for the hair cells. So it was luckily came out, turned out to be positive, and we made a diagnosis of this rare disease.
Thank you. Whenever you see something vague, something uncommon, something that you have never seen before, do think of a syndrome, do think of some other etiology, and that is what Professor Prabhat thought of. And see the impact on the patient's life. Proper genetic counseling, proper choice of therapy. Otherwise, we would have continued with metformin and kept on blaming the quality of metformin and other things. And now the patient will be able to live a productive and optimized life. Yes. With this, I'd like to thank Professor Prabhat for a wonderful presentation. Dr. Saab, apart from whatever you have taught other people, you've also opened my eyes and you've taught me a lot today. So I'd like to thank you for that.
Thank you, sir. Thank you.
And we'd like to hand over back to Dr. Anuj and his team. We need to unmute, sir.
Thank you, Dr. Sanjay Kalra, for the wonderful moderation, and we really enjoyed your moderation, especially in the time when the gaps were there and you kept the session live. It's really great, and we also always learn from you something whenever you are with us. So it's a great learning for all of our members as well as our faculties. Now we shall be moving towards the next part of the session. Dr. Muruganathan is already there. Dr. Muruganathan does not need any introduction, at least for the American College of Physicians members and fellows. Dr. Muruganathan is one of them, not one, only one of that person, only one that person who has made this ACP 3 times height. Earlier, when he has taken about less than 1,000 members were there, and when he has given it to me, around 3,000 members were there. So it was just 3 times height we could see in his tenure, and 200 fellows are already there in ACP. And most of the fellows which have been now as a ACP fellow, they all are made, most of them are made in the period of Dr. Muruganathan when he was governor, and he has made them advanced to the fellowship and elevated to that. So I could not find any other person better than him to tell about the advancement of the fellowship. Lot of questions are there in mind of our members as well as our non-members. Whenever we ask many people to become the member of ACP, then the first question comes up, what will be the benefit of becoming member of American College of Physicians? Simply becoming member is not a thing for which a person can join the ACP or can invest the money, annual membership renewal he should opt for. So always there is some kind of the things which are different from the other organization and which are added up to the person's curriculum as well as person's knowledge, which are being in addition to those which are existing as well as which are being taken from the other organization membership. So with this background, I would come up with Dr. Muruganathan I have already introduced Dr. Mugunathan in the beginning of the program. So I don't think any further introduction is required, and I think we don't want to waste much time in giving that formal introduction. So I shall be asking Dr. Mugunathan for the benefit of many of our members that what is this FACP and why should we look for this? Why should we get it? Is there any special benefit? So over to Dr. Mugunathan.
Thank you very much, Dr. Anuj. And at the outset, I must congratulate you for doing a lot of good activities, not only for academic activities, also improving the image of ACP, and then membership drive. Membership drive is one of the important chapter activity which you are doing. So I think this topic which you have chosen is really good, because so many people are asking, what is FACP, what is MACP, what is membership, etc. So if you permit me, I'll start with you asked me a very good question. What are the benefits? Forget about FACP. Just to become a member, what are the benefits? I've got 16 reasons why one should join American College of Physicians. Please allow me to share the slides. I'll just show you what are the important points. As I show, then you can also people can also understand when I speak and they see. Both eyes and ears can also get the knowledge about the ACP. So see the benefits of ACP. See, there are so many associations in the country. There are professional organizations, Royal College of Glasgow, Royal College of London, Royal College of Edinburgh, and what is the specific reason why one should join American College of Physicians? Anuj also will vouch for me. This is one of the biggest medical association in the whole world. They have got 161,000 members all over the world. We got more than 19 chapters, international chapters of ACP, and then there are 52 chapters in America itself. And it is the second largest after the American Medical Association. This is the association of American College of Physicians, where you get so many members. So when you join an ACP, you are joining with the 161,000 doctors across the world. That's a great advantage. And you will be proud to say, I am an ACP member. Why? Because of these reasons. I'll just give you some broad points why you should join, and then I'll give you subtle points in the 4 headings. The main thing is ACP's prestigious peer-reviewed journal called Annals of Internal Medicine is one of the top journals in the world. So you can get access to this. Then you get access to free evidence-based clinical guidelines, policies, and recommendations. Not only that, you get discounts on CME, meeting, courses, and products, including MKSAP. Free access to the most current evidence-based clinical decision supporting tool, Dynamite, very important. State and national advocacy to ensure the voice of internal medicine heard. Practice management resources and tools, and global network of colleagues to connect with the within person and online. So I'll broadly divide our benefits into 4 headings. One is called learning resources. What are the learning resources you get? The MKSAP. Many of you know what is MKSAP. So when you want to prepare for any exam, if only you go through MKSAP, there are 12 volumes, and the recent volume has come. And if you go through, and if you are at least 50%, if you are thorough, you can pass any exam. It's a multiple choice questions. MKSAP comprises of all these systems, including neurology, cardiology, everything. And then internal medicine meeting, you can connect with colleagues around the globe. And educational courses and recordings are available. And you get CME credit and MOC points. Then coming to clinical support. How is the clinical support is given by ACP? It gives Annals of Internal Medicine, clinical guidelines, Dynamite through ACP's collaboration with IPSCO. ACP members receive free access to this online clinical decision support tool, offering high quality evidence-based content at the point of care. And high value care, access case studies, best practice advice, and more to help you improve health, avoid harms, and eliminate wasteful practices. And then third point is practice resources. After the clinical support, what are the practice resources? Practice resources are ambulatory guidelines, get tools to help with the payment and coding, QI for financing management, selecting EHR, and more. Hospitalist resources. You can read ACP's hospitalist focused publications, resources for educators, physicians' well-being, and professional fulfillment. Your daily work, you must know, you also should take your well-being. So these are the places where you get lot of points about well-being to reduce burnout issues. And then for the last point is get engaged. You can do good networking, advocacy. ACP chapters, I told you, 52 domestic, 3 US military and 18 international chapters. So opportunities abound to meet other local internists and serve on local committees. If you are an ACP member, if you go to US, you can always proudly say I am a member, and you can connect where. Suppose you go to New York, you are going to Boston, you are going to Denver. Wherever you go, there are ACP chapters, and you can connect with them, and they will guide you, even not only for academic, even if you want to do some tourism also, you can do that. So you are very proud to be a member of the ACP family, so that everywhere you are getting some support. And you can do volunteerism with ACP, give back to the profession by volunteering to review ACP account. I'm very happy to say I am the volunteerism committee chairman, member in the ACP headquarters. And the ACP fellowship is the peer-reviewed and supported credential recognition, your dedication and your community and the greater internal medicine profession. As an internal medicine physician, it sets you apart from your colleagues and provides additional opportunities for ACP involvement and leadership. Now coming back to why and what is ACP fellowship, as Anuj asked me, I'll come to it one by one. It is a mark of respect, it's an honor. No matter what your role as internist, a fellowship recognizes ongoing individual service and contribution to both practice of medicine and your community. See, two things, individual service and, both the practice medicine and your community you are doing. Not only practice, also your community you are doing some service. And this FACP is given to people who are doing both the things. And the significant values, because it's a peer-reviewed, peer-supported honor. It's not an ordinary honor, it's a peer-reviewed, peer-supported honor. And ACP fellows embody means a part of the college through a demonstrated commitment to ACP, your colleagues and your practice. So commitment to ACP and your colleagues and your patients. The fellowship is a full due paying membership, and it is given for your accomplishment and achievements over and above the practice of medicine. So accomplishment and achievements is there along with your practice of medicine, and you pay the chapter dues, and you can affix the letter FACP after your profession. Now over to you, Anuj, for the further questions. I think basically I've given you why you should join ACP, and I also given you what is FACP. Now Anuj, over to you.
Yes, sir. Very rightly you said, and in fact, very rightly you given that why should one become a member, and because after becoming a member, then we can understand how should we go for the FACP. And in fact, the way towards FACP goes through the membership. So this is very much important to understand why should we become member. And then question comes, what is the FACP? You have very wonderfully described that what is FACP and what are the benefits of being FACP. Now question arises, who are the persons who can get the FACP? If anybody wants to elevate at the FACP, what's the characteristics, what the qualities and what the qualifications he or she should have in his or her, so to get elevated for?
Yeah, it's a very commonly asked questions for both Anuj and me. People, they join ACP member. People are more interested to use FACP after their name. So FACP means that they think only they'll have an ornamental degree or title or honor after their name. It's not only not that. The main aim of FACP, I've already told you, people know it's a peer-reviewed honor, peer-supported honor, and you are unique among the members. Not everybody gets fellowship. So to get a fellowship is not easy. It's not like paying the money and getting fellowship. So ACP has got certain type of eligibility criteria. So there are 4 types of ACP, FACP. One is called advancement, as Anuj has asked me. The second one is direct fellowship. The third one is called invited fellowship. And fourth one is called guided fellowship. So there are 4 types of fellowship available. I'll repeat. One is advancement, from the membership to the advanced. And the direct fellowship is you directly invite people who are very having high position, like Sanjay Kalra, somebody who's director, somebody who has done a lot of work, somebody has got research. They published a lot of articles in peer-reviewed journal. And then the third one is called invited fellowship. And the fourth one is called guided fellowship. So I'll come to one by one. What is the advancement for the advancement to the ACP? The current members who meet the criteria for fellowship, that is membership in good standing for minimum period of 3 years after post-residency. Please understand, 3 years. You know, people join ACP 1 year and they come and give a pressure to Anuj or me saying that, sir, I want to become a fellow. The criteria is minimum 3 years. Okay, somebody can ask me, sir, if after 3 years, can I get automatic fellowship? No, even that is not possible. Only with your dedicated work in the chapter, your dedicated work in the community, dedicated work in the volunteerism, then only you are eligible. So minimum criteria is 3 years, and not all 3 years can become fellows unless you do certain criteria. Like, you have to sign the application form, updated CV, detailing accomplishments since residency training, sponsorship letters, forms from 2 chapter current ACP masters or fellows. More important is recommendation from the ACP governor. As a current member, physician must demonstrate professional accomplishment within the fellows, their areas. The areas are published articles, multiple certification and teaching activities, 3 years of ACP members in good standing, leadership activities, volunteer activities, and ACP activities. So, ladies and gentlemen, please understand, if you are a member, if you have these accomplishments for 3 years, then you become you will be given fellowship by recommendation from 2 members and also from the governor. The second one is called direct fellowship. Who will become direct fellowship? Is a non-member internal medicine physician, is a national or international expert. It may be neurology also. The signed application form with updated CV highlighting accomplishment for the last 10 years and sponsoring letter forms from 2 current ACP masters or fellows and recommendation from the ACP governor. So this is not given to everyone. See, somebody comes and asks me, sir, can I become a direct fellowship? No, it should be given to a leader like dean or a director of medicine or professor of medicine who has done a lot of work 10 years and demonstrate excellence in teaching, contributes in scientific hospital research, demonstrated community activities. They've done a lot of work during COVID. And then 12 plus peer-reviewed articles they've published. So these people are eligible for direct fellowship. They need not be a member. They can be given directly fellowship. The third category is called invited fellowship. This is mainly for the non-published leaders. May invite qualified candidates to advance or the direct fellowship, providing they meet the requirement to be elected on their own. Membership in good standing for a minimum of 3 years of post-residency. And also, this is more applicable to the residency program. Updated CV after post-residency, a recommendation via email letter or from ACP leader, application form and other sponsoring letters required. If a current member fulfills all the requirements and they have all the academic activities, major medical center, director, chief executive, they can be invited. The last one is called guided fellowship. What is guided fellowship? Is a new full members elected through the automatic election process each year. Only members who are automatically elected in the year, they can apply for guided fellowship, and they will be required before fellowship is granted, must apply by November of the year, and they have to send CV applications. And this is a 3-year program with required activities to be fulfilled by the participants or invited fellowship after 3 years requirement are met. So these are the 4 types of fellowship which is available. So now, ladies and gentlemen, if you have any doubt, please write to Anuj or me. We'll tell you how to become a fellow. And fellowship is a very, very big honor. It's not just a letter. It has its own value. So the members who are joined now, do your activity 3 years and then ask for fellowship. And we'll go through your criteria. Then we have a steering committee, credential committee, which will scrutinize, and we give fellowship in every year 5 times. 5 times we get the application. March we are doing 2 times. So totally you have 6 times. You can now apply, and then after a credential committee scrutinizes your criteria, and if the governor recommends, definitely you will be eligible to get a fellowship. Over to you, Anuj.
Thank you, sir. Very nicely you have guided our members. How can they apply for the FACP and what is the best way? And everybody cannot get, and what are the basic requirements for that? So now I should ask you that what are the various opportunities to engage oneself with ACP if he gets FACP, and what are the basically if someone is honored of the FACP, then what is supposed to be do him? How can a chapter be benefited of his activities? Because we are having more than 200 fellows. We really wish that all those fellows should work for the ACP, for the advancement of the other members, those who are not yet fellow and those who are, they should also help them in academically. They should also become the mentor of many people. So would like to have your ideas as well as you enlighten us. How can this process be increased?
Yes, you already covered most of the points, Anuj. See, when you become a member, you are not a docile member. You should be actively engaged in chapter activities. You may be a good leader. You may be a good communicator. You may be a good service worker. You may be a research worker. So you will have to establish and give accomplishments in your interest. For example, you are a research man. You publish a lot of articles under the name of ACP with the help of ACP. After 3 years, you got some more than 12 articles published in peer-reviewed journal. You are eligible, and you are a leader. As Anuj said, you must be a mentor. As an ACP member itself for the local branch. Suppose you are in Lucknow, ACP member. You have to act. Call the IMA people, the doctors, practicing doctors. You must be a mentor to them. Tell them what you should do, what you should not do, how to do the practice, how to support the community. All those activities you must engage in chapter. I think Dr. Anuj has got so many committees. If you are interested, join in one of the committees where you are you have a passion, and then start doing even organizing work. Even membership drive. For example, I always give my quote: each one reach one, or each one catch one. For example, I am a member. If I can get another member and I get a point, the Governor Anuj will know, okay, so and so Muruganathan is good because he is now improving the membership development. And he sees Sanjay Kalra. Sanjay Kalra is good. He is giving teaching. He is a mentor for so many people. And you take Amit Gupta. He is doing a lot of service in the diabetic camps. He is helping the tribal people. During COVID, he has promoted vaccination. So like this, so many activities are there. Sky is the limit. And Anuj has got so many committees. You go through our Indian ACP India Chapter website, or talk to some of the advisory council members or me and Anuj. Get the committees, and then you involve himself. Show sincerely, and then make sure that you do some real good work compared to other person, and you will be eligible for becoming a fellowship. Mind you, you should complete 3 years.
What I understand, sir, that biggest benefit a person gets after getting the member of ACP and later on FACP, that he gets connected with the outside world. The outside world, which is outside of the India, is very well connected to us whenever we are member of ACP, because if we go to their conferences at the ACP headquarters or somewhere, wherever the conference is occurring every year, then we can come in the touch of the people of multiple countries as well as United States as well as European countries, and then we know that where we are and how do we are different than others, and how can we really improve ourselves, and what are the areas where we really need to do work more. So this is the biggest benefit while joining the ACP as compared to we see that other organization which we are working, which are working in our own country. So this is the biggest benefit a person can get. Many times people ask me that I am already a member of API, I am already a member of RSSDI, I am already a member of Indian Society of Hypertension. Then why do I need to become the member of the ACP also? So this one benefit I can understand. If you have any more benefit what a person can get, you can please add up to my words.
Yeah, that's what I already told you, told Anuj. I don't know whether you listened to it. See, get engaged. That is the important thing. What do you mean by get engaged? You got so many chapters, like 52 chapters in US, 3 military chapters, and 18 international chapters. So you automatically become the family of 161,000 members. So suppose your son is going to US or you are going to US, you can always talk to that local chapter. I already gave you examples. Philadelphia, you are going to Chicago. Wherever you go, you have a chapter. You can get their connections, advice. Suppose you are admitting a patient in a particular hospital, Chicago. You can ask the fellow there and they will come and help you. So many times I have recommended so many people going to abroad for any new treatments. I call my friends and colleagues in other areas and they come and help. They give you all guidelines. So you are going in, you will be groping in the dark if you go in states without knowing anybody. So they will help you. So as Anu said, I already given you 4 titles. That last title was get engaged. That is the most important. That's what Anu says. Apart from learning resources, apart from clinical practice, apart from practical resources, the 4th benefit is get engaged, where we say volunteerism, ACP chapters, networking, and advocacy. Yes, Anuj.
Yes. One more question usually comes up. Before I ask the question to you, I must say to many members, those who are already joined and listening us carefully, if they have any question regarding the advancement of the fellowship, they can write in the chat box and we will take up with Dr. Muruganathan. And so it is a request to all of you, anyone can write any question. So sir, what I understand, and many people ask me, if somebody is not working in some academic organization, in some medical college, and he is not having any publication. Even without having publication, can anybody become the FACP? Can anybody advance his membership?
Yes, Anuj, they can. I told you, there are a lot of avenues for your work. One need not be an academician to do research or to teaching. I told you, as a community man, you do a lot of community work. You do volunteerism work. You demonstrate you are a leader in the community. For example, there is a lot of disasters happen during COVID. You being a ACP member, you take the leadership role in that particular community. Do a lot of work, promote vaccination, promote health camps, promote advice. Then you are outstanding person in that particular area, and you give those accomplishments to us, and we'll scrutinize and we'll definitely consider you. If you are not an academician, if you are not a research person, and if you are doing hard work in these avenues, definitely you can become a fellow.
Right, sir. And very rightly and very nicely you have given the application process on the slide. So many people must have been noting down that how can they apply for the FACP. This also remains the biggest question by multiple people. They call me and they ask, how can I apply for the FACP? So this application is online application. You can go to the acponline.org, which is the official website of the American College of Physicians. If you are not a member, first you become the member. If you are already member and you have completed 3 years of your membership, you can go for the advancement of the membership in the FACP, and steps what you need to follow are being given here, as well as they are also being given at the site wherever you are going for the advancement of the membership as a fellowship, or you are going to take the membership. If any of you get any difficulty in that, you can contact to me or my office. You can leave a message to me, my office. In my office, Mr. Faisal is there, who is always ready to help anyone if anybody is getting any difficulty in membership. Amit is there, and Dr. Muruganathan, definitely he has always helped us, and he has always made us elevated to the FACP. I own my FACP because of him. So even Amit, you can also call to Amit. Amit can help you. Our all advisory council members will help you to get your membership and FACP, or any difficulty arising out of that. But one thing is very much important. After getting a membership, after getting FACP, you must prove yourself worthy for that. You must do something for your society which makes it useful of that society from which you are coming, and you can really bestow something good to your society in the form of some social activity, in the form of some health activity, like Dr. Amit and myself and a few of other doctors have started the project IRIS this year, which is for the women's health. Similarly, we can also find out some of the deprived segment of the society, and we start working for that society, that segment of the society, and that will be acknowledged by the ACP India chapter. And once we shall acknowledge the at the ACP India chapter level, definitely it will be given the acknowledgement by the ACP headquarters. I must say that all our activities, whatever we are doing here, which are in the good faith for the betterment of the people, for the betterment of the health of the various segment of the society, especially to the India is the diverse society. And this time our motto of the ACP is diversity and unity. And we must work for that and inclusion. So we must work to this equity, diversity and inclusion. And we find that most of the people, those who are in the diverse area, they should be getting equal opportunity, not only to grow, but also to get the good health, but also to get the good elevation in the medical field if they are working in the medical field as a healthcare provider. So ACP is working for all. ACP is the only organization across the world which is working for the medical students also. This is the only organization which gives the free of cost membership to the medical student. This is the organization which has its separate segment for the early career physician. And of course, there are so many other segments also in which we can also do a lot of work. If you are having any planning to work in your society and you are a part of ACP and you want to become the part of ACP, you want any favor from the ACP, you want that ACP's people should give you support, then you please write me. You please write me or my office. We are definitely there to stand with you, to help you, to work with you in any kind of the, if it is for the good of society, if it is for the betterment of the people, and it is the betterment for the health of the people. So I think we are completing. Amit, if you have anything to
one more point,
say.
what
Yes,
you have said about the leadership. Now the whole world is now having the leadership called JD leadership, JEDI. What do you mean by JEDI? J means justice, E means equity, D means diversity, I means inclusion. So ACP's prime motto is JD leadership or JD service. JD is what we know. You should not worry about caste, creed, color, region, religion. So it is equal and diversity. You should include everybody. That's why even ACP India chapter, we have diversity. We are including everyone. So that is the leadership which we are doing. And one more thing, because this completion, somebody asks me what mastership is. The mastership degree, which is a very, very great honor. And this was originally, in 1923, Dr. James Anders was the first person to get the masters. He was the president of ACP for 2 times. So this is mainly because of integrity positions of honor, impact in practice, medical research, and attainments in science and the art of medicine. So this master's degree, you will have to have governor's recommendation and 3 supporting letters to show and prove what you have done to the ACP, what your integrity is, and why you are outstanding, why we should give to master. So that's a very, very great honor. I think so. This is the complete of mastership, and people are asking some questions like who are not internists applying for FACP. I'm sorry, many people who are not internists, the credential committee will not approve fellowship if you are not an internist or general medicine person.
Okay, thank you, sir. Thank you for enlightening for this. I must remind to all our members that Dr. Mugunathan has been awarded the mastership of the ACP last year, and this has been a feather in the cap of ACP India chapter. So this is one thing which I must, although you must be knowing it, many times we have shared this in our newsletter, in our communication, which is coming from the governor. But this was the right time to say you again. And definitely Dr. Mugunathan inspires the whole of the ACP community by his own act. So he is the person he does something and he gives his own example. He set own example by doing things. So he has set an example to all of us, becoming the master of ACP. So this is an inspiration to each and every fellow of ACP. And I must also tell many of the fellows of the ACP, then you also do something like that, that ACP headquarters should start thinking that you should be elevated to the MACP or mastership. So I invite all the FACP to do such activities so that we can offer you the MACP also. Amit, over to Amit.
Thank you, sir. Thank you, Muruganathan, sir. So I think today we had one of the wonderful, most wonderful discussion today which happened. And sir, I would just like to inform, sir, we have also completed 1 year of our ACP India case files. So we started this journey last year in June. Now we are starting the second cycle of the ACP India case files.
I think it was the same day.
Yeah, it was the same.
Facebook has reminded me in the morning that 1 year before you have started this ECP case file.
So
I'm happy to participate in the valedictory of the 1 year.
Thank you, sir. And I think the case presented by Dr. Prabhat Agarwal was really wonderful. And many of the early our ECP council members have also joined directly on this platform. I can also see our advisory council member, Dr. Bansi Sabu, sir, here also. And one thing, sir, I would like to highlight. See, this is a session for the fellowship. So we have Dr. Manisha Gupta with us, and Dr. Manisha is has recently been awarded with the fellowship. So I will request Dr. Manisha, it is a good chance for you to get congratulations from our governor as well as the past governor.
I always appreciate Bansi, yes. Whether he is in the car, whether he is in the toilet, whether he is in the aeroplane, he attends the meeting. You know, sometimes when he is in the toilet, he may not show the video. Otherwise, you know, everywhere he attends now, he is driving the car and attending. Congratulations, Bansi, for your extraordinary involvement and interest and enthusiasm, Bansi.
Yes, and I also saw few people and few members, those who have been applied for the FACP, and today only I have signed the papers of his FACP grant. I'm not going to name them unless if they will be granted, but it was very good to see that they all have been connected here and they all were looking on this program very nicely. So it's really appreciable for everyone.
Thank you, Dr. Muruganathan, sir. Congratulations for 1 year of this program, online ACP program. Thanks to both the leaders, and congratulations both the leaders, who is current president, current chair of ACP India Chapter, Dr. Anuj, and immediate past president of ACP India Chapter, Dr. Muruganathan. Congratulations, and with a wonderful activity done by ACP India Chapter.
Thank you, Dr. Bansi, for joining us in this prestigious program. And last month, Dr. Bansi Sabu has advised us about the mentorship and issues related to the mentors and mentee. And that was also a very wonderful program reminder. And we really look forward to have him again in some of the program next month or next to next month, whenever we will get an opportunity. So I think this is the time we should.
Yes. Dr. Manisha wanted to say just one thing, sir. Dr. Manisha is newly elected fellow of the ACP, sir.
Good evening, everyone. And I'm really feeling obliged to be here on this platform. And it was really good to connect to you all. I am Dr. Manisha Gupta, presently practicing in Mohali. And I'm working with Shelby Hospital, Mohali, as well as I have my own clinic here in Sector 65. So I did my MD in 2004, and since then I have been practicing in Tri-City.
So congratulations, Dr. Manisha, for being conferred fellowship of ACP. So
when did you get the when did you confer the fellowship, Dr. Manisha?
That was 4 years back, sir.
No,
4 days back. You received a communication.
4 years. Communication.
4 years.
No. Membership. I received communication around 1 month back. It was in June. I received first mail. Yes.
Okay. For fellowship, you have been given the communication 1 month back.
Yes.
Okay. So definitely it is a matter of heartiest congratulations to you, and we will be looking forward to see you in our Visakhapatnam Congress to honor you there as a new fellow, as well as we will be looking forward to your presence in our next year San Diego ACP annual conference, where you may be getting an opportunity to attend the convocation. So
yes, sir, I will definitely try to be there.
yes, get
Most
ready for
definitely.
that. And
Yes.
others people, those who have not applied for the FACP, but they deserve for the FACP, I will request them to apply for the FACP so that they can also be offered. I really wish from my bottom of heart that every physician of India should get the FACP, because everyone deserves it. When I see that our Indian physicians are working from 7 a.m. morning to the 10 p.m. and they are looking so much of the patient, 100, 200 people OPD, I always think, and this always comes to my mind, that they are the people who deserve for the honor. So this is my wish. I don't know whether it will be fulfilled ever or not, but I wish that every physician of India should get FACP.
Sir, with those words, sir, I would just like to mention one thing, that today we have ECP council members and they must have learned a lot. So now we need to carry the torch which Dr. Muruganathan has handed over to Dr. Anuj Maheshwari, sir. So we need to work hard for the ACP India chapter to make it shine and rise more and more. And our membership should become more and more strong. And all of you should think of becoming an FACP, and every advisory council and everyone will be fully supporting you. And let me tell you just one more thing. ACP India chapter is one of the most transparent chapters. Everything, the voting is online, the selection is online, the process is totally transparent. And whatever you write to our governor, and you will definitely get some sort of reply and consideration. And whatever projects you want to do, nobody gets that much freedom, because I myself have experienced with the ACP India chapter, that whatever you want to do, you can do with the ACP India chapter, as long as we are not crossing the lines or the limits. So everybody is most welcome. So I think we should disseminate this information to all the membership, to all the early career physicians, all the non-members also, to increase the membership drive. Thank you again, once again, Dr. Muruganathan sir, Dr. Anuj Maheshwari sir, Dr. Prabhat Agarwal, and Dr. Sanjay Kalra sir for being here for this episode. Next month we are again. Next month again we are going to have a very interesting case, and we have already started to receive applications to present the case. And I have just one forwarded to Dr. Anuj sir. So he will look into this and we will consider that case. So thank you very much. And we will see you next month again for the ACP India case files. Thank you.
डॉक्टर अमित, एक चीज और मैं यहाँ पे शेयर करना चाह रही हूँ.
Yes.
Please.
हेलो.
Please.
एक because आपने बताया कि this year you are planning for women wellness only, and
women health program. Yes. Women health program, and this program is a tripartite program. You can say that 3-tier program. In the 1 tier, there is a women health checkup camps. You can be a part of that. You can organize these kinds of the camps in your place, in your clinics, in your college, wherever you are working. And second thing is that we are thinking about to go to women schools or girls school or girls colleges to give the awareness lectures regarding multiple issues of the women's health, women, even for the hygiene, even for the women health like PCOS, even for other issues like cervical cancer, vaccination for the cervical cancer, and other adult vaccinations which are usually ignored in the women. Multiple things of the health are ignored in the women, but they are still being done in the male. So we should always be making them aware about that through those kinds of programs. And third one is left. Third one is left. That is CMEs and webinars, what we are already doing like that. So these are the 3-part and 3-layered program, and you can join at any layer which is comfortable for you. Yes.
ठीक है सर. सर एक चीज मैं यहाँ पे बस एक शेयर करना चाहती थी अपनी कम्युनिटी के साथ कि रिगार्डिंग विमेन हेल्थ, एक्चुअली अभी रिसेंटली यहाँ पे पंजाब में एक आइडियाथॉन हुआ था इन चंडीगढ़ यूनिवर्सिटी, एंड आई पार्टिसिपेटेड देयर. वहाँ पे एंटरप्रेन्योरशिप आइडियाज देने थे, जिसमें माय आइडिया वाज वुमेन वेलनेस क्लिनिक, to run a women wellness clinic, and it was selected as the best idea, and I received prize money of 25,000 by the Punjab government, and they want to take up my idea as a startup idea here.
Okay, very
that
good.
is,
So you
yes.
can write that idea to me at the as the ACP governor email ID, and
Yes.
we will be sharing that idea to all our members. That
Yes,
and we
sir.
will also share that you have been winning the award with 25,000 rupees, as well as the
So
25,000 is
basically,
not
yes,
important, but
yes,
honor is
the idea
important.
was
So
was
yes, yes. So you can write
in my
that, and we
day-to-day
will
practice
communicate, and we
because
will
as a
send it to
female,
all people.
okay,
Not only those who are
yes,
attending
sir.
this
ठीक है
program,
sir.
we will communicate
Okay,
that
sir.
to all
Okay,
members of the ACP about that
ठीक
idea.
है,
And
ठीक है.
other peoples also, those who are having a very good idea, they have not even given anywhere, but they want that this to be taken by someone, they can write me, and we will give appropriate honor to all ideas.
Thank you, sir. Thank you. And I will request all the listeners who are also part of RSSDI to join the other meeting at 9 p.m., which is for the Save the Feet campaign. Again, Dr. Anuj is going to be there because he is coordinating the state chapters. So, sir, I will request you to be there
Yes,
at 9 p.m.
definitely.
And Dr.
I will be
Murunathan, sir, we
joining.
also request you to be there because we want your support for the Save the Feet campaign of RSSDI. So, though this is the ACP forum, but I thought I would share because
already Vijay Viswanathan told me about this. Because
Yes,
Vijay was interested
For
in it.
every
and he told
good
me.
thing, you are always welcome to say anywhere.
Yes.
If you
Thank you,
anything
sir.
which is
Thank
goodness
you.
for the people.
Thank you from the ACP India chapter, and good night. And let's connect on the other platform. Thank you. Thank you very much, sir. Good night.
Bye bye.
Thank
Thank
you,
you, Dr.
Thank you very
Murunathan.
much. Thank
Good night.
you.
Thank you, Amit.
Thank you, sir. Bye bye.
Bye, everyone.
Bye.